I have 93 slides for today. So aside from staying here till 8 o'clock tonight, I won't do everything, I promise. I mean, people are looking slightly horrified. But we will have a class tomorrow morning from 9 to 11, okay? So that way we can, because, I mean, this stuff is important. I mean, some of you, those of you who are clinicians may have been a little frustrated at times the previous parts of the course, because it's all very abstract and, you know, social sciencey. So this is where the rubber hits the road, and we should give it due time to sort of talk through it, eh? So, and also just another, en passant, it's not too important, but just, because two of my slides, just so we can get beyond the 19 up into 21 already. So these are these two tables, which are in an article, which I think was not published at the time that we put the readings together, but which we could find a way to send you, which is an editorial in the latest issue of our journal called Rethinking Cultural Competence. So it has a table that really reprises some of the stuff that we're talking about here in terms of matching at different levels, cultural competence really at different levels, not matching, and then the pros and cons. So it's a kind of summary of some of those issues, including of cultural safety. So I think I've said almost all these things already, so I can just skip those slides. So that's what those were. I did want to mention this, which is an important point made by Dan Savin, a psychiatrist in Colorado, about the ways in which cultural difference affects the clinician-patient relationship, and particularly psychotherapeutic relationships, because in part of the professionalization of medical care was to define the clinician's role in a very particular way and to build a set of professional ethics around that role. And this becomes particularly acute in the context of psychotherapy, where, as those of you may see the David Cronenberg film, A Dangerous Method, the sense was that this is a dangerous method because you are spending a lot of very intense emotional time with people, a lot of forces are set in play, and it's very at risk for abuses of the power then, and the emotions and the feelings and the attachments and so on that get activated in that setting. So it's in that context that we've had very rigid sets of guidelines for what a professional role is, and in terms of psychotherapists, that you should not touch a client, that you should not accept a gift from a client, that you should not be giving gifts to clients. The degree of austerity varies with different schools of therapy, different types of practice, and so on. But in general, there's a lot of concern about these boundaries and about the risk of boundary violations. And this idea of the boundaries in the role of the helper are part of a certain kind of social definition and configuration of the professional task, and of the neutrality of the professional, and of the trustworthiness of the professional. The problem is, again, given that people have different models of what a helper is and different etiquette for different situations and so on, that certain ways of defining these roles can become misunderstood or communicate the wrong message to someone. So there are contexts, societies, where more informal exchange or friendliness with people is important to establish trust, or to repay your debt to someone, to show that you appreciate what they've done, or to really just manage the relationship. So Dan Savin took these things into consideration, thinking about intercultural work with people coming from different places, and argued that we're not just talking about technique at the level of instructions for a certain kind of therapeutic practice, but the regulation of the relationship itself, and that we should have a kind of a grid where we think about what kind of modification are we talking about? Are we talking about accepting, about having tea with a patient and sitting and talking to them? Are we talking about accepting a gift? Are we talking about going to an event, a family event, let's say, that's happening outside? I think he gave the example of being invited to a wedding in one of his patients' families and deciding, does he go or not? And what would it mean if he doesn't go? What would it mean if he does go? And trying to understand this, not only from your own terms, in terms of what the profession says, but in terms of what it means for the people that you're working with. And that the way that we might approach these is not by having an absolutely rigid rule, which in the end, if we have an absolutely rigid rule, that's there not to protect patients, it's there to protect the profession. It's a simple way to protect the profession. We make an absolutely rigid rule. Nobody can ever accuse us of ever doing this because we just don't do it, and if you did it, okay, you've broken a rule and now we have to be censured by the profession. Or we say, look, the real goal, the most important goal here, certainly protecting the profession is worthwhile, but it's not the most important goal. The most important goal is helping the patient. And maybe there are situations where being able to accept a gift from someone or giving them something or being able to go to a family event might be a very, very powerful, constructive intervention in that process. And we need a way of thinking about that. And so he argues we should have a kind of grid of what is the riskiness of the thing that we're doing and what is the benefit. And so the greater the benefit, the more risk you're willing to undertake, and the less the benefit, the less risk you should be considering. And so rather than having a rigid rule, we could have a grid and a process then for discussing with colleagues, with supervisors. I mean, the general rule of thumb in these kinds of, if a situation is very complex, you should not be doing this just in your own head, but you should be doing it in dialogue with someone else who in that way begins to share some of the responsibility with you, at least informally, for figuring out what the sensible approach would be. But this calls into question, just raising this whole issue and giving a framework for thinking about it does call into question the idea that we already have a recipe for all these things and one size fits all. I'll give you another example of this that comes not from this issue of ethical dilemmas surrounding boundary violations or boundary crossing but from just everyday notions of how much activity or agency should a patient have and how much accommodation should a clinician make. When I began working 30 years ago at a hospital where I worked, there was an attitude that you give a patient an appointment, and if they don't show up, well, they don't really want care. They had it at a certain time, and they're voting with their feet, or they're showing they're not motivated, they're showing they're conflicted. So, too bad. Maybe they lose their place, or they certainly, you don't make great accommodations for that. There's evidence from work of Jean Miranda at UCLA that if you want to provide psychotherapy for depression for people from lower socioeconomic backgrounds with a lot of constraints in their social world, like taking care of children and trying to make some money and all these other things with limited resources, that having a lot of flexibility to be able to get together with them is very important. And calling people to remind them when they need to come is very important. And coaxing people along and making it easier, et cetera, is very important. So that is, in a way, you could say, acknowledging some of the social reality of the context that someone's in, and coming down off a kind of ivory tower position of, look, this is here for you, now you must make the trek. It's more like the Himalayan mountain, I guess. You must make the trek to the top of the mountain to get the pure gold of this treatment, and being in a much more of a negotiating and supportive role to help people to achieve what they're doing. So that's another example of trying to understand people's life's context and make some modifications or build some flexibility into a system so they can respond better. Okay. Now, I wanted to mention a broader ethical issue, which I think is important for us in all of our reflections. And I'm not sure this is the ideal place to do it in this discussion, but it's here in my slides, so I'm going to try to make a natural segue to it. And that has to do with how we understand the empathic process in therapy. I don't recall, I may have shown this at the beginning of the course. Is this slide beginning to look familiar? So maybe I did this already. But I spoke about alterity, but I didn't show the slide. This is going to end up at a more complicated slide. So, okay, we'll see in a moment. We'll see, maybe it'll look familiar in the end. But let me do this little riff on this anyway. So generally speaking, in psychotherapy and in clinical encounters in general, we think that communication is important, and that part of that communication involves an empathic process. That is, people are telling us things about their lives, but we're also feeling things in their presence that help us to get a clue as to what they might be feeling. Somebody looks very, very anxious, and we feel a little bit uncomfortable, and that gives us a clue of the level and intensity and perhaps even a bit of the kind of anxiety that they're feeling. And we show that to them by mirroring that. We say, it looks like you're feeling really anxious, or I can see that you're feeling really anxious. And so we're kind of giving them an empathic response. Or they say something and we repeat it in some way to show that it's really registered with us. So we show that we're paralleling them. So this is an important process. And in fact, there's evidence coming from sort of humanistic psychotherapy, client-centered therapy, Rogerian psychotherapy, other kinds of schools that have emphasized this process just of empathically mirroring another person as a fundamental kind of therapeutic intervention. You could think of it another way, another dimension of it is just bearing witness to people. You can work across very diverse cultures, and to be a sympathetic listener to somebody, says, tell me what happened, what have you been through, and just listen, can be a very powerful experience for someone if they feel it's safe to tell you, well, I've never told anybody, but this and this happened. So that process of confiding and of you listening in a way that I would say is not simply neutral, that it's not that you're sitting with an impassive face, because that communicates something. It's not neutral. If somebody's telling you sad things and you look completely impassive, you're not communicating neutrality. You're communicating emotional distance. So if somebody tells you something sad and you show just a little bit of sadness in your face or compassion, they feel like the message is getting through, and we are, there's some understanding there, and I can continue to tell my story. So this is this process that we're talking about of empathy. And there's a lot of interest now in the mechanics of empathy, because we're learning some things about the neurology of empathy. We know, for example, there's a social psychological research on what's called the chameleon effect. If you sit in a room with someone and watch them closely, listening to them, your posture will tend to shift in synchrony with the other person's posture. If you're listening really closely, your breathing may synchronize with the other person. And this generally happens without you being aware at all. So there's this kind of mirroring. And we think we know what might be a little bit of the neurology behind that with this idea of mirror neurons, right? It turns out that there are parts of the brain that light up whether you're doing an action or whether somebody else is doing an action, that same action. That you can show that there's a kind of parallelism, and that people have argued developmentally that may be how we acquire empathy and mutual understanding and so on, that it's a system around which things like imitation learning and so on are built. So this is some of the discussion that's occurring around what might go into empathy, the ingredients of empathy. A couple of things to say about that. Empathy is not 100% accurate, right? And empathy, your sense of what's going on with someone else is affected by whatever's going on inside you in the first place, or what the other person's experiencing does for you. So if somebody looks intensely anxious to the point that they are afraid something terrible is going to happen to them, and for example, I'm thinking of working in an emergency room, seeing an extremely paranoid patient who's like looking like this and really, really terrified. It doesn't simply make you feel what they're feeling, it makes you feel something in reaction to what they're feeling. Right? So, in fact, your capacity for empathy may be derailed by the intensity of what another person's feeling, because you don't want to feel that. You're really defending against it. You're having a counter feeling. So it's just to say, even though there's this potential we all have to be in synchrony with each other, it's part of how we learn emotions in the first place. It's part of how we feel close to people and understand each other. It's also something that is a dynamic process that we're grappling with all the time, and we're having a mixture of feelings, some that might be in synchrony and some might be reactions to it and ways to manage it and so on. So it's just to acknowledge that, and that in a dyadic interaction you can think of, as with other emotions and other communication processes, you can think of empathy as not being a one-way thing that somebody just experiences, but as being intersubjective. And what that means, one way of giving concrete meaning to that notion, is that there's a kind of a loop going on between you and another person, that things are going back and forth. So you're feeling sad, I hear that, I start feeling a little bit sad, you see me looking sad, it changes your feeling, and we're in a kind of a loop now where we're kind of coming, maybe even converging potentially on certain feelings. So an empathic experience, the point is an interaction. It's not simply like a one-way moment, okay, I got what you're saying. It's, I think I got what you're saying, and I'm showing that I think I got it, and then you're registering whether I did get it or not. Maybe it's not quite what you thought. So that's empathy. Now, there are situations in psychiatry where, because people have certain kinds of problems, the ordinary process, the everyday process of this kind of tuning into other people is impaired, it's affected. Either they're having extreme experiences that you've never had, they're really hard to fathom, or they're exquisitely sensitive to things. You can have a moment where I had worked years ago with a woman who had great personality and relationship difficulties, and there's a point where I was feeling this great compassion and attachment for you, and she suddenly said to me, I feel like you're looking at me like I'm a dissected frog on a table with pins stuck in me. So that was not what I was feeling. So, I mean, and I thought that I was hearing, she was talking about just before that, talking about some very sad things. So it's in the dynamics of her own inner struggle, that rather than perhaps staying with this mutually almost enjoyable feeling of being with the grief and being together in the grief and experiencing a moment of human solidarity, she suddenly felt like she was being flayed alive and naked and exposed in horrible, horrible things. So that's related to a certain kind of psychopathology, a certain kind of, past injuries that happened to her and that were being replayed at that moment. The question is, in therapy or in trying to understand people, what do you do when that happens? How do you manage that? Because one reaction is, of course, to recoil or to feel like, I just can't understand this at all. This is beyond anything. And then the relationship breaks down. The communication breaks down. So, in fact, what happens in training in mental health practices is that people learn models for these things. The stories I just told you, those of you who studied psychopathology or work with people, they will be somewhat familiar. And you'll say, yeah, I've heard about that, I know about that, I've seen people like that, and there are some theories about what might be going on for those people. And we can use those theories to patch the gaps in our own ability to track the other person's experience. So we say, okay, this kind of fear is a paranoid fear, I understand, it's not an ordinary fear, it has certain dynamics, that's why it's hard for me to go there all the way, that's why this person's not experiencing my concern as reassuring, and I can work with that. I can use that knowledge now to reassure myself, first of all, to try to stay steady, maybe to explain it a bit to the other person, to both of us, what seems to be happening here right now. And I use that model both to give some insight to myself and to the patient, but especially to regulate and to maintain this kind of sense of, okay, we're sitting here, we're talking, we feel some basic human understanding. So this is one side of this process. So in fact, you can use your intellectual model, your abstract model, your knowledge of psychopathology to help you regulate that empathic process. And so that you don't experience the feeling of being abandoned or violated or discounted by the person that you're trying so hard to understand and so on. There's another way in which things can break down, which is people start telling you a story or describing experience and it's beyond your experience. It's strange, it's bizarre. And somebody describes, this, written about this, I think you've had in some of your papers and so on, about refugee contexts where people start talking about various kinds of violence that they've experienced and where the therapist grew up, here in Canada, and this is so far beyond it, other than reading in some newspapers or some Hollywood movie or something, it's so far beyond anything they really could imagine that they can't go there. It doesn't make sense to them. So what fills the gap there is some knowledge of the real world, of the social world, of the different cultural contexts. And in a way, it plays an analogous role to this knowledge of psychopathology, that it becomes a way to patch the gap where you say, I don't really understand what's going on here, but I've learned enough now about this. So a person, for example, starts telling you, my daughter did so-and-so, and that is such a blot on my honor that I think she should die. I mean, take a concrete example that has occurred. And so you have this dilemma of saying, I really don't understand what would it be like to be a father who felt that way about his daughter, felt so strongly. So to get a glimmer of that, which doesn't mean condoning it incidentally, but it means being able to work with it, to understand it, to have a conversation with somebody, to figure out what's going on, you have to understand that social world. You have to have much more understanding of what else has that person been exposed to, what goes on in that context, and so on. So you begin to understand what honor means, what father-daughter relationships mean. So that is the way in which the whole content of cultural psychiatry that is encouraging us to look in some kind of in-depth way at the social world, the social context, the cultural context, is helping us with this very basic task of simply tuning into somebody, having a meaningful conversation, getting some glimpse of what it's like for them in their inner experience and in their social world. And I think these things interact in the sense that your knowledge of the social world helps you to understand these psychopathological processes. Why is this particular thing going to be so powerfully humiliating for you, this kind of social event? And why is this then going to interact with the fact that you're vulnerable in that way? And so on. So we could say, on the one hand, we have models of psychopathology. On the other hand, we have stories of the social world. And then we have mechanisms that explain why certain features of the social world affect certain psychopathological processes. And it's that we're trying to put together in formulating a mental health problem. This is the whole content of cultural psychiatry that is adding to what the rest of mental health practice has. And interestingly, there's a spelling error here with Einfühlung, but this maps onto an older phenomenological language. You have on the left explanation, and in the middle you have empathy, and on the right you have understanding. Right? So explanation, you can give an account in terms of mechanisms or what's going on inside the person. Empathy, you can tune into the feeling and have some glimmer of the feeling. Understanding, you know what this means in context for somebody in some ways. This is not precisely how these words were used, but I think it's an interesting notion that, and these were originally debates phenomenologically and within social sciences about modes of understanding phenomena. And the argument here is they all have something to contribute to the clinical process of making sense of people's lives. Now, clinicians are deeply invested in the idea of having this empathy, and it's not only a tool for what we do, I would argue it's a reward for what we do. That part of why people are attracted to psychotherapy, aside from wanting to do good, is that they enjoy empathizing with other people and learning about other worlds and feeling like they've tuned in and so on. And whether this is reparative for some early experiences they had of either too much or too little empathy, or whether it's just an inherently interesting thing to a lot of people, it's definitely one of the rewards of the profession. It's one of the things that makes people decide why this rather than that. People go into medicine, there are lots of things they can do. They can look at pictures all day long, or they can hammer on bones all day long. Those who want to listen to stories all day long are definitely a particular subgroup of people. So, and what is it that attracts them to it? So part of it is this interest and this valuing of the tuning in and connecting and feeling mutual understanding with people. However, that has its own dilemmas built into it, because then it means if you don't understand somebody, you're failing and you're disappointed in what you were expecting to have happen. And unfortunately, under those circumstances, there may be a tendency for us to deny or to exaggerate our own failure of understanding. And so this is why, one reason why I think the philosophy of the phenomenological philosopher Emmanuel Levinas is particularly interesting, because he confronted the reality of both the necessity of empathic understanding, the fundamental basis of empathic understanding as the beginning of ethical awareness and consciousness, but also its limits. So Levinas was a philosopher who was in the tradition of Husserl, a student of Husserl's and of Heidegger, but became very concerned is too mild a word, with the way in which Heideggerian philosophy seemed to not have an answer to the political violence and the dehumanization that became part of Nazi Germany. And Heidegger was a card-carrying Nazi for a number of years and expelled his own, or helped to contribute to the academic expulsion of his own teacher, of Husserl. So this was a big problem for many people. To this day, it's still an interesting problem. There's quite an active debate to this day around this basic question: how much does the content of a philosophy relate to the personality of the philosopher or to the politics of the philosopher? Can you separate the philosophical system, which many people admire and find great power in, great value in, from some political errors? The error being not only joining the Nazi Party, although he quit eventually and tried to distance himself from it in some ways, but he never, in his entire subsequent career into the 50s and early 60s, I guess, never wrote anything repudiating his own actions. So this is a big mystery and a big dilemma for many people. Anyway, that's a whole other story. But the important thing for Levinas was to try to think about phenomenology, about the nature of experience, and about the ethics of experience, to think it through in such a way that might give us an understanding that would obviate or prevent that possibility of dehumanizing to that degree. And basically, the argument he tried to make and tried to argue that this was intrinsic to the human condition rather than purely prescriptive as to how we should live, was that ethical awareness, what we mean by ethical awareness or moral consciousness or whatever, begins with the recognition of the face of the other, and of the face of the other, as not us. And you can take that, I mean, when a psychologist hears that, we think right away, we think developmentally, we think of like a baby looking up at the mother's face, you know. And I think Levinas was interested in that, but that's not how he was thinking, how he was arguing this. He was arguing this on phenomenological grounds, so he was arguing this is intrinsic to the human condition at every stage, and by face he didn't always mean literally face, but he meant the presence of another. But it includes the face, because that's one way that we commonly experience the presence of the other. The voice is important, all these other things are important, but face is particularly important because of all that is displayed on the face, the individuality of the person, their emotional feeling. That's what faces are largely for. I mean, we have all these extra little muscles on the face, so we can do a lot of communicating with the face. Some of them are there to close our eyes and keep dust out, but some of them are there to primarily to communicate emotion and to speak. So Levinas argued that this face of the other gives us this primary imperative for ethical responsibility for them, and it presents us with alterity, with otherness, because there's some other person or consciousness there that is not our own, and the point then is that we can never fully know that consciousness. Yes, there's empathy. Yes, we developed our own awareness in dialogue and interaction with others, so there's the opposite argument that comes from Wittgenstein that you wouldn't know what pain was if you weren't part of a social world that teaches you what this fully means. But it's also the case that with any given person, our knowledge of them is always limited and always incomplete and always will be. They may have new experiences, there'll always be new depths. And that then presents us with this unknown before which we have a responsibility. So it's not just that we get to be responsible for the things we know and like, but we have a responsibility for others precisely in the ways and the aspects of their being that are strange or unfamiliar. So that's a big moral challenge now. That's getting us into this biblical injunction of the stranger at the gate. How are we going to deal with the stranger? What kind of hospitality are we going to show for the stranger? And this is the kind of ethics that he tries to build. Now, the part I want to emphasize is this, not only this responsibility of hospitality, of care, of concern, of protection before the vulnerable other, but this notion of limits, that there's a limited understanding we have of other people, and we have to learn to tolerate that. And the reason I think that's important for mental health practitioners is because, as I say, and just professionals in general, because we're supposed to know everything and have all the answers, that it's painful for us to tolerate and respect and tolerate the limits of our understanding. I know this is, for those of you who've been taking the Working with Culture course, this is a major theme in that workshop in terms of dealing with the realities of this and how one manages this, both in terms of oneself and in the institutional settings one finds itself, which do not generally give much space for that. You're supposed to be a competent professional. You should just have the answers and do things. But I think it's very important that we leave some space for this in the process, and I think you can find lots of justification for that and lots of thinking that through in the philosophy of Levinas. So that's what this is here for. I want to switch slightly now, the last segment, in talking about this services. Now, we still haven't gotten to the second part of the talk today, but this is the last part of the first talk, which is around mental health services. And I want to talk about the cultural consultation model. So this is another strategy for dealing with addressing cultural diversity in healthcare in a way that allows us to do something that will improve services without reconfiguring all the services, without creating specialized clinics or saying that everybody has to do something differently now, of saying, let's take an existing healthcare system. Is there something we can graft onto that existing system that will improve the quality of what's being done? And the natural model for this in terms of primary care and psychiatry in North America and other places is to think of some kind of consultative process, because that's how a lot of different kinds of expertise get introduced into a basic kind of mainstream care. Collaborative care is another kind of model that would be more ongoing, close collaboration.
So the cultural consultation model that we've been studying for 10 to 12 years now, based at the Jewish General Hospital in Montreal, has a series of steps. And the basic notion is that we're providing an in-depth assessment of the social and cultural dimensions of complex cases. I say complex cases because that's what usually gets referred to us, and that's when this kind of in-depth assessment is most appropriate and needed in the healthcare system. That in-depth assessment is done, as we'll discuss more, with the cultural formulation and with the use of interpreters and culture brokers. And the idea is to take that information, formulate the case in understanding how culture makes a difference, and then use that to provide the primary care clinician or case manager with the information needed to negotiate a plan with other clinicians, with the patient, with the family. And oftentimes what's needed is not only negotiating a plan around what the correct diagnosis is and what the appropriate treatment is, but linking the clinician with specific resources that might be part of the treatment, finding a community organization or group that could help with the treatment or support the patient, finding specific skilled practitioners who can, for example, treat sequelae of torture in a refugee claimant or someone like that. And overall, even though the focus is on a specific case, which is a very natural way to engage around the primary concerns of a clinician, the goal is really knowledge transfer, knowledge translation. We're really hoping that whatever expertise the cultural consultation team has is being transferred to the referring clinician. That is, through the experience of understanding this one case better, they're gaining some more general skills that they can use in other contexts. And the service, even though this is generally a one-off intervention, that is, we're helping to assess the patient at a particular point in time, the service remains available for follow-up to help later on. And overall, the goal then is also to assess the effectiveness of this kind of intervention, to show that it's a worthwhile and cost-effective addition to the healthcare system. When you look at the corpus of cases we've collected over the last decade or so, you can see a pattern that most consultations take 1 to 3 visits of about 2 hours in length.
These figures are all old, so they're all just very rough approximations. So about 70 different countries of origin, about 25 cases from only one country. So this again speaks to this very, very high level of diversity where it's hard for us to have any established expertise. It's like it's a whole new dilemma to find somebody from that background. Very many different languages, many different religions. And in general, we've used about 65 or so now, I think, culture brokers with these cases. 17 and 17 different clinicians. And interpreters are used about 2/3 of the time. We get a large proportion of people who are refugee claimants. So these are people who've applied for asylum and who are in a kind of a limbo waiting to know whether they'll be accepted and be able to stay. And many of whom have been exposed to very high levels of violence and have complex mental health issues that are plaguing them and that are likely to have long-term consequences if they're not addressed soon. This just gives you a picture of the origin. None of this stuff is particularly important in this, other than our own neighborhood, but it's just to make the point about the general diversity and so on. What we do in the service, a lot of the cases, the most common thing is a diagnostic assessment. That's what people are asking for. But that's also what we say we do. We say we do diagnostic assessment, treatment planning. So those are the most common reasons for referral. They're not always the only or the real reason for referral. One of the real reasons for referral oftentimes is limitations in the healthcare system itself. That is to say, certain services are not being provided. They're not readily available, whether because of the person's status, in the case of a refugee claimant, or because it's just a complex service that's needed and it's hard to find. And so anytime a new specialized service is available, people will try that. And we also get just difficult cases. We get people, let's say, with chronic problems that have not been well addressed. And so people hope, well, let's frame this as a cultural problem. Maybe we'll get something for it over there. There's a fair number of cases where the main need is just referral to a particular resource, whether people realize that in the first place or whether we determine that, you know, all you really need is to know there's a good community organization that can provide some of the things you're looking for this patient. Or what you really need, we think, is an interpreter, and you should work with an interpreter, and we can try to set the person up with that. The tool that we use in general for the formulation of the case is the cultural formulation in DSM-4. And this is an outline that lists some areas that can be used to assess different aspects of a cultural problem. 4 main areas: the identity, cultural identity of the person, their illness explanations, their psychosocial supports and functioning, and their view of the clinician-patient relationship. And those 4 dimensions are supposed to be assessed and then integrated into a cultural formulation. So this, I mentioned early on, was something that was introduced in DSM-4, and that we have an expanded version that we provide to our consultants, that we say this is a set of topics that you need to explore and use to formulate the case in cultural terms. Our expansion of the DSM-4 outline mainly has some more detail on migration, because in DSM-4, people were not thinking so much of immigrants. They were thinking of these ethno-racial blocks when they were sort of making it up, so it tends to talk about that or mention those kinds of issues, not migration issues. It integrates more our interest in different kinds of explanatory models that I've alluded to, and it addresses some systemic issues. We've looked at people's use of this, and one of the things we found that's interesting is that most people, until recently, have been very unaware of the presence of the cultural formulation in DSM-4. So again, I think I mentioned this early on in the course, that even though those of us who were involved with this whole process with culture in DSM-4 thought it was a wonderful idea, the cultural formulation, and it ended up in the second to last appendix in the book with relatively little incorporation into everyday care. There's some light at the end of the tunnel. We're hoping that with DSM-5 it's going to be at the beginning of the book, and there will be not only an outline, but there will actually be a cultural formulation interview, which has 16 questions that ask people about particular areas that could be explored, and that this would be encouraged to be a routine part of assessments. And then you can go in more depth when you think specific cultural areas are problematic, but it would be some very basic framing. And you can find an early version of that cultural formulation online right now. The APA is asking for public commentary on the material to get feedback before moving forward. So what happens when we do these formulations is we come up with a reassessment. And that reassessment may include many things. It may include the various social dilemmas a person's facing and structural issues and so on and so forth. But it also may lead to alterations in the most basic psychiatric assessment issue, which is what diagnosis is being attached to the person. It's not the only issue, of course. When any clinician works with people, what's really important is a kind of problem list, in a way, that the person may have certain symptoms, they have certain diagnoses, they have certain social problems. All those things are important, and they may be a kind of list of different things that have to be attended to somehow. But diagnosis is particularly important, partly because that's how psychiatry defines itself. It likes to think that we've got these discrete problems, we're identifying them, we have discrete treatments for them, partly because they influence things like funding and insurance. They have prognostic implications. They have stigma attached to them. There are lots of social implications. These diagnostic labels, as we've discussed quite a bit at different points in this course, have a social life of their own. So the act of diagnosis is quite important for people. And what's interesting is that it turns out when you do this lengthy process of collecting a lot more information about people's social and cultural context, using interpreters, using culture brokers, you have a very high rate of new diagnoses, of changes, of new aspects that were not discovered before, of rejecting certain diagnoses that were made and deciding they're not well-founded. And this is just a very crude way of reporting that. We're in the process of doing a much more refined and accurate analysis of what this means. This is simply totaling up the total number of people who've received each of these kinds of diagnoses at intake coming into our service. So they've had this label attached to them, and at the final evaluation. So it's not matched person to person. So we're not tracing with this kind of very summary table what happens to person A who had such and such a diagnosis and later went on. We're saying, okay, of all the people that came to us, of 175 people had a diagnosis of an affective disorder. 150 people had major depression, and 25 people had bipolar disorder. That's how they were referred to us. They came in with that diagnosis. The next column tells you, of those, let's stick with the depression people for a moment. Of those 150 people with depression, we confirmed 75% of them. So that means in 25% of cases, we did not agree with that intake diagnosis. We said, no, we don't think this person has depression. They have nothing, they have something else, whatever. Of all the people coming to us, the 382 people that are here, we found 70 people who had depression who had not come to us with depression. They had other labels when they came. So that's the next column. And then the final column is of all the people, so 183 out of the 382 altogether had a diagnosis of depression at the end. 113 of those when they first came, 70 afterward. So what you can see in the final column is of all the people who had depression, 38% of those were new diagnoses. So it's very crude because, as I say, it's not matching case to case. People can have multiple diagnoses. It's not really helping us to see what's the hierarchy of diagnoses, or what, because some of these changes might just be because certain diagnoses trump other ones. If you're giving one diagnosis, you don't have to give the other ones. They're not all here. Somebody with major depression, for example, would not get a diagnosis of adjustment disorder with depressed mood. If they have major depression, they don't get a diagnosis of adjustment disorder with depressed mood. They don't need it. So there may be processes like that. There are various reasons why this is very crude, but it still gives you a rough sense of the very significant impact of reassessment on this very basic act of diagnosis. I should say we do have some work, we have done some work where we have traced patients. Ademola Adeponle has done a study, which I may have mentioned earlier, where he took patients who had a change in diagnosis from psychosis to no psychosis, or from no psychosis to psychosis. And in that case, it's individual patients where we know this person went from this to this. And it's only those people that we looked at, and he analyzed what were the determinants of those changes. So we know something about that. That's a paper that's been published in Psychiatric Services. Here's some other diagnoses. And these are, in some cases, they're groups of diagnoses. We don't have enough cases to break things down. In most cases, these are groups of diagnoses. And the frequency is a complicated issue. I mean, it reflects who gets referred to us, and that's a complicated story about our whole healthcare system and who likes us and who's aware of us and all kinds of other factors. It's not telling us very much. But what I do suggest we look at just for a moment, I'll go back, is look at the last column and look at the ones that are very high. So, let's not talk about schizoaffective, but let's go down to adjustment disorders. So 92% of the diagnoses of adjustment disorder are new diagnoses that we make. So that's very interesting to me. I mean, it speaks partly to the fact that in psychiatry, people don't diagnose adjustment disorder very much because it's not viewed as a very serious problem, and it raises issues about reimbursement and all the other things. So it's better to have a more severe label if you're trying to convince people this person needs time off work, their treatment needs to be paid for, et cetera, et cetera. But it also reflects the fact that we are spending a lot of time understanding what is the context that people are living in. And we are identifying a lot of problems that are related to acculturation, that are related to other things. And although acculturation exists, I don't know if we even have it down here. We didn't put it down here. Well, here, acculturation exists as a V code. You see the line there that says V code. There's a category in DSM, again, at the back of the book, that are life problems or circumstances. They're not things that are really psychiatric disorders, but they can be clinical problems. So a acculturation problem is a V code. Marital problem is a V code. It's not implying that you have a psychiatric disorder as such, but it's a kind of problem that people often bring to mental health practitioners. And so this was a compromise for how to find some way to have them in the book, but not give them the position or the connotations of a full-blown psychiatric disorder. So those are also underutilized, in fact, by clinicians. The other thing that you see, now where is it here, that you'll see that's very high on our part, it's back here, is personality disorders. And this speaks to the idea that to make a diagnosis of a personality disorder, you have to be convinced that the patterns of behavior, the problematic patterns of a behavior a person has, are long-standing. They go back to at least adolescence, if not to childhood. And you can really trace them as being fairly continuously there over the course of the person's life, because you're arguing this is somehow intrinsic to the development of this person's personality or character. And that's why it dogs them all over and they keep running into this kind of problem. Well, that's often if somebody's migrated or doesn't speak the language, or you don't have a lot of past history, it's a very hard judgment to make. If you're judging it against different norms of what's acceptable behavior, it's a very hard judgment to make. We talked earlier in the course about judging whether somebody is overly dependent, for example. It's an extraordinarily difficult judgment to make if your standards of independence are you should leave home at the age of 18 and go live on your own. then there are a lot of people who are not meeting that criterion. So many clinicians, I think, respect the fact or are aware of the fact that they don't feel fully equipped to judge what is the norm against which I should assess that this person is too much or too little, is too dramatic or too obsessive or too this or too that. So they defer that kind of thing. We're able to do that with a little more confidence, partly because we get a lot more history, so we know a lot, what was this person like as a childhood, we've talked to other people, and because of the culture brokers or cultural consultants we have who we can ask pointedly, well, compared to other people from that background, does this person seem to you much more this or much more that? So they can say, oh yeah, this is way, yes, it's true that people like to, stay with their family, but this person is way, way too caught up in all this. This is not usual for somebody from their background. So we can say, okay, even taking into consideration what is normal development in this culture, this person is not negotiating that in a typical way, so that tells us something. So you need that kind of normative frame that you're getting from your own experience working with a lot of people from that background or from somebody who has that kind of knowledge from the community. So that's a little bit about that experience. The treatment recommendations are all over the place, sometimes because we're seeing psychiatric patients, and we're seeing people who have severe mental illness. We're seeing people from, again, the refugee clinic who have complex post-traumatic stress disorder and psychosis and other things who may well need medication. So there's plenty of that in our recommendations. There's also lots of recommendations for social interventions, people who are socially isolated or who need to build up social networks and intervene at that level. There's somewhat less recommendation for psychotherapy. There's lots of recommendation for specific therapeutic interventions. That is to say, okay, the person's already getting psychotherapy or something, but we think there's a very particular thing that they need. They need CBT for, medically unexplained symptoms, or they need some kind of treatment for PTSD secondary to torture. So we're sort of referring to some more specialized thing, either that the existing clinician can do or that needs some other expertise. So let me go back then just briefly, because the slide I'm looking for that I don't have is a slide that talks about the themes in the cultural formulation, which really should have come before the treatment recommendations, because the cultural formulation is not only a diagnosis, that's one thing. It's got other axes, as in the DSM-4, where you have an axis where you describe social stressors and you describe level of functioning. But it goes well beyond that, so that we're trying to talk about we're formulating things. So we're trying to talk about, well, what are the issues? What are the processes going on that are problematic? So there might be some discussion of family systems issues or intergenerational issues or so on. So what are the common themes? Well, the most common themes have to do with systemic issues, whether in the healthcare system itself, that this person's got into some problems here with the healthcare system or the educational system or something else. Systemic issues in the family. Again, related to migration or intergenerational issues or other kinds of things. Trauma-related issues, because we see a large proportion of people who've had significant kinds of trauma. I'm trying to remember now this whole list. Those are the top three. Intergenerational issues, I think I've already mentioned. Identity issues, so conflicts that are associated with how a person is negotiating their own identity in this new social context or vis-a-vis their family and so on. And interestingly enough, there are a few other things, but near the bottom in our own referrals are cultural differences in explanatory models. And we were puzzled by that initially, because that's, if you go and think of this course again and think of medical anthropology, there's lots and lots of talk about all these interesting different healing systems and theories of illness and so on. And these don't show up so often as central to the main assessment of the problems. They may come up, people have different ideas, but they don't seem so central. And I think there are 2 or 3 reasons for that. One has to do with the selection process in terms of who's getting sent to us and who sees a clinician in the first place, because those who are most deeply embedded in traditional systems and other ideas are not going to the doctor, are not getting referred to us, some of those people. It's also, once people are in the biomedical system, they don't always talk about or reveal those other things. So yes, they maybe have other issues, but they don't put them central to their presentation, so they don't come to us that way, and we don't get very involved in that. Also, people have multiple explanations. So people say, yes, it's this, like we talked about around Indigenous issues the last time. Yes, I ghosts can play a role in this and so on, but they don't need to talk about that. They focus on the parts that they think are going to make sense in the biomedical context, so we tend not to get drawn into that. We have had some interesting cases where different explanatory models and different desire for different treatments were central to the cases, and often they were central because of conflicts with the clinician. That is, the patient wanted to try something else or was doing multiple things that were consistent with their own belief systems and so on, and the clinician felt very worried or threatened about this, felt it would be bad for the patient, it wasn't safe. Think of one man who had a psychotic illness, that was not responding that well to medication, and his family decided they wanted to take him to the Caribbean to have some traditional healing by Obeah. And the clinician got very concerned, and also part of this was that they already knew that he would have to stop taking his medication, his antipsychotic medication, to clear out his system so that the herbal remedies and things that the Obeah man would be able to do would be effective. This was very worrisome to the clinician, who was very concerned because she felt that if he stopped taking the pills, he would get much more psychotic, and she had visions of him being on the plane and losing it, and she just saw the whole nightmare. So she became very, very confrontational with the family, very upset, and really telling them, you can't do this, and almost saying, it's either the pills or me, kind of, like you either do this or I can't work with you anymore. So we called in she did refer the client to us saying, help, I'm getting into a real bind here. A Caribbean psychologist who saw the family and who spent time understanding it from their point of view, and who was then able to help mediate the process, because she came back to the clinician, what she was able to tell the clinician as part of this consultation was, first of all, the family really like you and really trust you and think you're a great doctor. They're very puzzled as to why you're making this into this either or, because they would like to come back to you. They do feel that their son has not gotten really that much better with the treatment he's had, which everybody agreed, that's really the case. Understandably, they want to try whatever they can, given that this is a serious illness. And they're quite prepared to take the pills with them, and at the first sign that he's really losing it, give it back to him again. So we went from a polarized situation of kind of breaking down a useful helping relationship, where it seemed like this is a terrible either or, to this ability to renegotiate it that respected the family's search for healing and so on. Now, as it happens, he got the Obeah treatment, and he was significantly helped by that. Well, I don't have long-term follow-up, so I don't know. I'm not going to tell you that this was a magical cure of psychosis by Obeah, although it's entirely possible, since there are psychotic illnesses that recover spontaneously or with various treatments. We don't fully know. The important part for me is just how we manage to negotiate and help people negotiate some kind of ongoing supportive relationship that was helpful to the family and to this young man by avoiding this intense either-or process, and that this centered around different understandings. But part of the different understanding was not that the family believed devoutly in Obeah and that spirits were causing this problem and so on, or that herbal remedies were really the source, but that they believed what most families believe in this situation, which is we have to try everything that makes some sense or could work, whether or not we really believe it. And there's Murphy Halliburton's written years ago, wrote a paper in a journal called Finding a Fit, where he argues that one of the situations in India, for example, is that there are many, many different kinds of treatment available. And so people can try to find a fit between what their resources are, what their beliefs are, where they are geographically, socially, and so on, and something that might help a bit. And that freedom and flexibility to try different things can be important for people with a whole variety of problems. So that's one example of where a different belief system, if you will, or practice was at the center of the consultation. Well, these are just categories we made up for coding purposes, so it doesn't mean that it's a brand new professional. I did not explain it, and you're right, it's a little bit of a weird category here. In this case, it was, okay, we think some kind of a new professional needs to be involved. This person needs a psychologist. This person needs a social worker. This person, I was just look at the other categories, because I don't think there's any other category, and these are not mutually exclusive categories either. So I don't think any of the other categories here really fit that. Yes, there are times when we would say, this doctor is the wrong doctor for this patient. And the reason it's not that frequent. No, that's relatively infrequent, because again, our whole goal, our whole philosophy is that it's just, first of all, it's not realistic. Maybe in an ideal world, we should all be able to mix and match until we find the good person for us. But it's just not feasible given limited resources. So we're not going off that end. But there are times where we say, look, this is just a very bad fit, and we don't recommend that this person keep working with them, either because there's no need at all, we'll find something else, or because, it's part of the problem, not part of the solution at this point. Well, it depends, and I have to think of individual cases. I would say in the few cases where it happens, often the health professional is relieved. Because the truth is, there's a significant number of cases where the health professional is really hoping that we're going to say, fine, we'll take this person off your hand. Because again, we're getting difficult, complex cases, so often the health professional is feeling a bit exhausted, a bit demoralized. That's one kind. The other kind we get very enthusiastic health professionals who are very committed to their patient, who really care and really interested in the cultural dimensions. That's probably most commonly what we get, because doing this process, referring a patient, getting this consultation, it's extra work for the clinician, not less work. I mean, they have to write a referral note, they have to make contact. We invite them to come to the case conference. In some cases, they actually come and sit for an hour and listen to the whole discussion. There's a lot of ways in which they're putting themselves on the line by saying, I need help. I mean, you don't get a lot of strokes in our healthcare system for doing that, although you do get in trouble if you don't say that when you should. So, very easy. Let's take a non-cultural example. A woman who has had an experience of rape, and she's a very well-intentioned male clinician, and in talking with her, we get information. I mean, this actually has occurred not just around the gender issue, but around the gender-culture intersection, which makes it even more complicated, because again, gender means one thing in our society where we're pretty egalitarian and there's lots of exchange. It can be a more complex, fraught issue in another society where there's much more segregation of the sexes. So we can come back to us and say, look, given this person's feelings about this and so on, it's going to be very hard for you to really help them. I think we need to help find this person a therapist of the right gender. So there's an example. If it was around religion, let's say, it would be more delicate, but you could imagine again a situation where saying, look, it's not your fault, but this person just doesn't feel enough trust under the circumstance. They really need somebody from the same religious background or somebody from another one, because they're having there's too much interference going on with them. Because we can say that without condoning it, and without condemning the patient. We can just say, look, here's the scenario. If that's the case, there are usually reasons why. It's intelligible why it's such a big issue for that person. And as I say, usually under those circumstances, the therapist is very relieved, because who wants to be stuck in such a difficult situation? Right. So, the more common situation is we're putting input into the situation, sometimes additional help, and then the therapist is able to go forward. So the dramatic example is in your paper. I use this one all the time. I may have even mentioned this already. I use certain examples are getting overused in my own repertoire here. So, but it's of a woman who's referred for intractable depression from one of our local clinics. She had been in treatment with somebody for some time who knew her quite well, who had a range of skills. The person was a non-medical practitioner, but had psychotherapy skills, family therapy skills, was doing a range of things, and was getting an additional consultation from a psychiatrist who was writing the antidepressant medication. The woman had been tried on 10 different antidepressants. She was not getting better. She was still very suicidal. When she was assessed by our service by a bilingual, bicultural clinician who was able to get more of her story, it turned out that this was, I should have to say more, that this is a person from South Asia, that her daughter had married into another family. There was a feud between her family and the other family. The daughter had had a baby, and because of the feud, she had not seen her daughter or the baby in like 2 years. She was very, very upset, very angry at her husband, who was really the one who was most intensely engaged in this feud. When the problem the problem had not come out clearly even though she had good rapport with her therapist, but not super good communication, and it was never explored in the right way. And when it came out in front of her and the husband and so on, and the therapist or the cultural consultant who understood this context very well, did not assume that, okay, now we can all fix it. She assumed probably this is going to continue to be a fairly intractable problem. But she acknowledged just how difficult and how painful this was for both of them, and how maybe in their own way the couple were both feeling something similar, although they expressed it differently. That had a huge effect on the thing. So and then this person went back to their usual therapist, but with something new to talk about and with a bit of a logjam broken up, and was no longer suicidal. She's still miserable and upset and angry, but not totally furious with her husband, because he now acknowledged, how, and some potential. One of the interventions was to say, if you were back in your country of origin and a problem like this occurred, who would be involved in helping to broker this? Because there may be people of another generation or another status or another position in the larger system who have the freedom and the power to comment on and to try to mediate some of these breakdowns that are very hard for separate families thrown into this new situation to negotiate. So that might eventually lead to some kind of a change. This model that we've developed has been interesting for other people because it makes very few assumptions about the healthcare system. There is a funding issue, which we haven't solved, I have to say, at all. But it's something that, if there is some funding, could easily be tacked on to almost any kind of healthcare system. Because just another kind of outpatient consultation, there's plenty of precedent for that in other places. And so you just need to build up the resources, the interpreters, culture brokers, people with some basic skills in this kind of evaluative process to be able to offer that in different settings. And there's interest in a lot of different places now. These are some of the places where people have been doing some similar work, and there are others now. There's a group in Israel that's trying to develop this kind of work, and so it just lends itself to be flexibly adapted and sort of begin to be used. And as I say, I think the goal is not that we're going to reach all the patients who need this, but that we're going to serve a kind of educational process in the healthcare system, so we're upgrading the skills, we're increasing awareness, and maybe additional types of service gets developed. Our biggest problem is that we see many cases where what would be ideal is that somebody gets a kind of psychotherapeutic or psychosocial or culturally adapted treatment, and there's nobody really able to do that in their language or in a culturally appropriate way. So we're left with very rudimentary interventions because it's hard to find that, or finding therapists who are willing and patient to work through interpreters and so on. Now there is evidence, good evidence, that you can do psychotherapy through an interpreter. You can do pretty much any kind of psychotherapy through an interpreter. You can do psychoanalysis. You can do behavior therapy, certainly, cognitive behavior therapy. It's just time-consuming and laborious, and people don't like doing it for that reason. Everything takes twice as long. People get tired and bored. So you have to be committed and realize it's very important work, and and there are people who are willing to do that. So this is a manual from Sweden, where the Transcultural Center that we help to support a bit through joint educational activities, developed a manual for doing a cultural formulation, which was given to every physician in Sweden. So there are efforts going on. How deeply they penetrate into people's practice, I don't know, but they're certainly worthwhile statements about what people are considering important. And the healthcare system obviously thought it important if they're willing to pay for this nice booklet being given to everybody in the system. And this has been translated now into Finnish. It's been given to Finnish doctors, and I believe that there's a Danish version. So that's the end of the first half. The rest is not as long or as involved, and we'll do some now. We'll just see where we're at kind of as we go through this. But I don't want to do it in a compressed way because there are a few things important to talk about. So, but let's pause. So any questions, comments, things, because I'm going to shift gears a little bit, stepping back a bit more to say, okay, where might this be heading? I guess in talking about that sorting for cultural consultation, I'm describing one strand of where things might be heading. People hopefully are going to do more of this. It's interesting, if you look at that list, one of the sites is the people at the Centre Minkowska. This is a program in Paris that was established in the 50s in the wake of the Second World War for refugees, and focused on giving mental health care for newcomers. And they're very interested in the cultural consultation model because the general attitude in the healthcare system has been, fine, we'll send this person to the Centre Minkowska. So it's nice that they have their own special program and they have a bunch of psychologists and social workers and other people trained to work there, but then they're left with this frustration that we're not really transforming the healthcare system, we're not transforming the society, and that's a very important issue for the long run, not only because they can't treat everybody, but because there are larger societal issues that are addressed by getting everybody to be aware of these things. Melissa Dominici Dow is working, she's an internist. She came and did a master's here in transcultural psychiatry. She works in a general hospital in internal medicine, and so she's working in a model of incorporating cultural consultation into medical care in a highly diverse population. So just to say that I think the model really lends itself to a lot of very different things. The Transcultural Centrum in Sweden does not do much patient evaluation. They do mainly in-service training. So they're using this model, but they're using it in case conferences at other sites rather than sort of doing individual cases. They began in a model closer to what we're doing because they were attached to a specific service.
I was just wondering, in terms of like incorporating this into people's, like into med school, for example, right? Into med school, right into counseling psychology, like that seems like it would kind of like, you know, prevent sort of problems from happening to a certain extent. People were made more aware of this, like right from the start of training, because like in undergrad psychology, this is entirely glossed over, you know. To a certain extent, from my experience at least, like people kind of mention, oh, you know, in Japan they have this thing. Anyway, moving on. But like if it was included in like graduate training, like actual clinical training, like has anyone talked about that or?
Yeah, there's a lot of interest in that, a lot of work on that to the extent that there are training guidelines and regulations, and those exist now for clinical psychology and for psychiatry in the US very clearly. In Canada, a little more ambiguously. So Andrew Ryder is involved with the Canadian Psychological Association and other people to try to develop eventually, I think, guidelines. We just published a paper for the Canadian Psychiatric Association on guidelines for training in cultural psychiatry that appeared in the Canadian Journal of Psychiatry just last month. And that's a very ambitious document because we just took the high road and listed everything under the sun, all the things you guys have been exposed to and more. We said all psychiatrists should be exposed to these things. I mean, realistically, we'll see how much time people get. Even in our own program, people only get a few half days in terms of the core teaching. If they want to do more, they have to come take this course, basically. So by no means a few people do, a handful of people do. What has to happen is multifold. There have to be these guidelines. They have to be turned into accreditation standards so that people say, sorry, you can't run your training program anymore with the imprimatur of the American Psychological or Canadian Psychological or all the other organizations that endorse these things unless you have X many hours of such and such. And we want to see that. We want to see they come by every few years and they want to see the documentation. That has to be there. And then the resources to do it and to do it well have to be there. So one thing we're hoping to do with our training document is to turn it into a kind of living document on a website so people can go and find a list of topics and then click on that and they go to a bibliography and maybe they go to some videos, maybe they even go to some of these videos or other videos, and they can say, okay, we don't have anybody on our faculty right now who likes to teach this, but at least we can get started, and then we can certainly chair a good discussion in our seminar and talk about the dilemmas of integrating this and so on. So that's, I think, the next step. And then what has to happen is a lot more research on how this actually plays out. Because the dilemma is, again, as I said, it can be very superficial. It can backfire if people, a little bit of knowledge just leads to stereotyping rather than real engagement. It's really about attitudes and about modes of inquiry, of how you explore things. So those are skills, high-level skills. You have to see how people are really acquiring those. Otherwise, yeah, it can fall back onto, oh yeah, I heard about this weird thing in Japan. That was very entertaining, that thing. Which is less than helpful. I mean, it's like, again, the little knowledge is a bad thing kind of thing. Better they should know nothing about Japan and simply be respectfully interested. I mean, that would be a good place to start with a Japanese client, let's say. So my concern is that content gets into the curriculum at all levels. There's a lot there. As I say, the thing that we put was more like a lifelong learning program. Like something should be in medical school and something should be at each year of residency or each year of graduate training, and then some things are for you to come back to as a practitioner when you discover what setting am I working in, what are the issues, what are the emerging issues. They're going to be changing things. And then I think there are core issues that can happen and have to happen soon. I think that we need regulations. First of all, I think everybody needs to be trained in how to work with an interpreter. So it's not a big mystery. It's not something you're frightened of or how do I get started. You have some simple guidelines for how to do this, and you're confident that you know how to do this. And everybody has to be required to work with interpreters legally in certain situations. That has to become a standard of healthcare. Without that, as a professional, you are liable. You're just not doing a good job. When that happens, then the practice will change. Because that's the other issue. We know for all kinds of other things that there are all kinds of good things that clinicians can do that they often don't do because they're under time pressure, because they're difficult to do. What really makes a difference is when there's some kind of monitoring, when there's some kind of standard, and you're going to be held to it, then you see dramatic changes in performance right away. And often people don't even need more education for some things. I would say culture, I say in area people do need more education because I hope you've got a sense that there's some nuanced issues that we have to get a handle on. But things like recognition of depression in primary care, for example. I mean, there's studies to show that all you have to do is come back periodically and say, look, about 10% of your clients probably have depression. You don't seem to be diagnosing them. What's going on? I'll be back in 3 months, and things will be better the next time you come back. Just that scrutiny enables people to use the things they already learned more effectively. And so there's certain things that are just like that, I'm sure. But there's a larger framework. And the largest framework, and that's what the second half of this talk is going to be about, is what is our attitude toward these issues of culture and diversity? Because I think I mentioned at the beginning of the course, when I began doing this work, I would say people were becoming more and more interested in this. And then I think we went through a real heyday, maybe, 10 years ago, 10, 15 years ago, and all across Europe people were excited about multiculturalism and so on. And now we're in a big, bashing culture mode. Who needs this stuff? People should get over it. They should all integrate, assimilate. We're tired of accommodating, et cetera, et cetera. So we face a real problem. Or that's the negative side. The other side is, it's really all the social determinants anyway, and economics and education and whatever, so let's just focus in on that. And I've already given you a bit of the answer to that, where I say if you do take that seriously, you're forced back to considering all these more complex issues of culture if you actually want to make a difference in those other things. So those are some of the strategies, I guess, in terms of creating the materials, easy access to them, and then institutionalizing the requirement that people have to do these and that somebody's going to check to see whether they are doing these things. Because they're already there, actually, for the most part in training requirements, but they're there in a very sketchy way. In the Royal College, because in Canada, training of psychiatrists is governed by the Royal College of Physicians and Surgeons. That's the official professional body that is supposed to set standards of training and of specialty certification. So they just went through a huge process of refining and revising their training goals just a few years ago. And they do mention culture in the document in about 3 places. So it's just not enough. And what is, it just would leave a training director scratching their head saying, okay, but what does that mean? I need a lot more information on what is going to be the guts of this if I'm going to start teaching people this or setting up a program. So that, in effect, that's what we tried to do. So what we mean by culture, and here are the 20 different sessions you need to have and the topics that need to be talked about, and here's how they, where you could find some of this material. That's what we're trying to do. So I think that this is one of our future topics here, because for this whole discussion of the future of cultural psychiatry, that it needs to be more institutionalized. And to my mind, there are 2 broad arguments for this. One is the political argument that you need to have recognition of people in society. People insist that who they are be recognized in some way. It's only groups that are marginalized and silenced that just say, don't have a voice and don't say that. But you also need to address this because of substantive reasons, because there are demonstrable differences, demonstrable health disparities, because they have an impact on health outcomes. But to really understand that better, we need a lot more research. We really don't have enough research. And when people say, well, where's the evidence? For example, where's the evidence that the cultural formulation really makes a difference? We have to say, well, it's very thin on the ground. Very, very thin on the ground. What we have is 65, 70 papers that are individual case studies of cultural formulations. Sometimes they tell very compelling stories of how there was a whole new chapter in this person's care. So that's important. It doesn't tell us how big this phenomenon is, but it tells us in a graphic way, yes, in this case it really made a huge difference. And we can imagine or identify many analogous cases. That's not considered hard evidence by people who do health economics or evidence-based practice. That's anecdotal. It's given very, very low priority. Single case studies have almost no recognition within the hierarchy of kinds of evidence and evidence-based care. Although, as I say, realistically speaking, if something is a compelling story where you see it was going along in such and such a way, certain new information came into play, and for reasons you can obviously see, that information was relevant to a new approach that then led to a radical change in outcome, it should count for something, I think. If you believe the source, it should count for something in that story. But it's hard, other things could have happened, could explain the thing. It's understandable why this is not enough. We have some isolated studies of the type I mentioned, like showing that ethno-linguistic matching of case managers to patients makes a difference for adherence to treatment and rehospitalization in severe mental illness. We have a handful of these kinds of things, and even in the general medical literature, because this whole issue of cultural competence goes well beyond mental health. In fact, most of the activity has not been in mental health, most of the activity has been in general health care. And there are several reviews that have tried to pull all this together and say, what is the evidence that interpreters make a difference? What is the evidence that cultural competence makes a difference? And the answer is it makes a difference, it seems, but there's not nearly enough evidence to be really confident, or to say more specifically, here's the kind of situation where it really makes a difference, or here's the components that really make it a difference. We really just don't have enough of that. So there's many careers ahead for people who want to look at this stuff. It's not easy to get it funded or supported because, again, it tends to be treated as a frill. Yes, it's there, it's important, but it's so downstream from, or going to be such a late chapter until we figure out what really works. So then the argument has to be made, maybe it's more central to what really works. Maybe there are ingredients that are going to be looked at in this process that should be included earlier on. But that's a harder argument to make. I think that has to be considered. Right now, as I mentioned already, with DSM-5, there's a process of trying to develop this cultural formulation interview and trying to field test it, just at the level of, is it acceptable to people? Is it doable? Does it make sense? Do patients find it a reasonable way to explore their problems? And that's being tested at about 10 different sites around the world, in India and Spain and Latin America and other places. And the hope is that the group that's doing that will become a kind of consortium going forward, and that various paradigms that can actually look at whether cultural formulation make a difference compared to standard care, compared to other interventions. For example, we're interested in doing a couple of studies. One we're interested in doing is, how does this short interview compare to the in-depth assessment that we do? Because it's one thing if you can do something in 15 minutes, that might get quite a bit of interest, quite a lot of people would be willing to do it. It's another thing to tell you it takes 3 hours and a lot of different people. Under any circumstance, that's going to be reserved just for very difficult, very complex cases, right? I mean, this is now big time intervention in terms of cost and time and so on. So it's an important question. Some of us are doubtful because clearly a lot more goes on with 3 hours than can possibly go on with 15 minutes. Not only just of all the different people you can talk to and how you talk to them, but even just of building enough trust with people that they're willing to tell you certain things. I mean, our experience of doing the McGill Illness narrative interview for an hour or two is that the story changes dramatically over time because people begin to feel more at ease and they go back around certain things and reveal other layers, as is very natural. So, or even just how they, never mind the trust or issues of trust or defensiveness, it's just even a cognitive process of how you organize your own memory and your own reflection, that not all of it's going to come to mind unless you have enough time and space. So it's hard to imagine what we're going to get out of those 15 minutes, but hopefully it'll be of interest. Another paradigm is to compare the cultural consultation, for example, with just using an interpreter. Standard care, but just using an interpreter. Because our impression is that probably is one of the single most powerful things we do. That it's not that we have such magic questions we ask people that nobody else knows to ask, or that we're such wonderful people that people tell us things they wouldn't tell anybody. It's that we just have better communication because we have an interpreter there, so people can express themselves much more freely and in much more depth, and we get a lot more information. So the combination of an interpreter and taking more time is a huge part of what we're doing. So if that's the case, fine, that'll be great to actually show that concretely, and then to ask, what additionally do we get, or what kinds of things do we get that require a more culture brokerage, more deliberate insertion of culture-specific information. That's not, so I think that's another kind of set of paradigms that could be useful. I also think that there's the opportunity to develop new forms of treatment. And this is one area where you can make the argument that this whole issue of cultural adaptation, or looking at tailoring things to people, is not just a question of political recognition or a little icing on the cake that we'll do later when we know what really works, but maybe it's a way to understand better what really works in the first place. And one obvious example right now in contemporary psychology is the fact that there's been widespread interest and quite a bit of research to show the efficacy of mindfulness. And mindfulness, which is a kind of meditative practice that comes directly from Vipassana or Theravada Buddhism, central to kind of meditation central to most kinds of Buddhism. It turns out to be extremely helpful for a lot of things. That it can help, with a certain small amount of tailoring. It can help people with chronic pain. It can help people with anxiety. It can help people with depression. It can help them both acutely, and it can help them prophylactically. That is, it can help prevent things. And there's RCTs. There's lots of material. So even a very hard-nosed, evidence-based person can say, this is pretty interesting treatment. We need to do more. We even need to understand what's going on in the brain when this happens, and so on. Yeah, now it's real. We can see it in the brain, and the brain's changing when we do it. So, incidentally, the brain changes in psychotherapy. So, Eric Kandel wrote a whole article to argue that, and then there's drawing on other people's studies to show that, look at this, when somebody's treated, the brain changes. And in fact, in psychotherapy, depending on the condition, in some cases you can show the change in psychotherapy in the brain is exactly the same, or exactly the same. It's very crude analogies we're making because we're just looking at very crude changes in the brain. Very coarse level analysis, but you can show some of the changes that are occurring with psychotherapy are the same as the changes that would occur with pharmacotherapy, because you're writing again these regulatory systems. To me, it doesn't make, if the person gets better, this doesn't make it any more real. It maybe eventually will help us understand a little bit about mechanisms, but we're still far away from understanding what those would be in some cases. But there's an example, and then we have other therapies that have also been borrowed from Buddhism or from other traditions. We have acceptance and commitment therapy. So this is another aspect of coming from Buddhist cultures, particularly again sociocentric cultures, where the notion of your moral obligation to other people is crucial. So the notion that you can actually use that as a way of getting people into a better state of mind by making, by accepting certain things and by making certain kinds of commitments to things, and you can embed, or compassion therapy, another kind of CBT that's been modified. So these are all boring elements. Now, you could take it a step further. This is what we may have our Advanced Study Institute on next year. I'm hoping that we can get organized to do that. You can ask, okay, so we're taking these different healing practices. They're actually not healing practices in situ. Meditation is not strictly a healing practice except metaphorically. It's a path to enlightenment. So it's a spiritual practice, if you will, or an ethical practice. And we're taking those and we're sort of psychologizing them and we're packaging them as technologies and we're taking them out of context. And they still do something. That's interesting. But what are we losing in that process? Or what are the larger social consequences? So this is where I think we come full circle, because we can talk from a narrow efficacy point of view as clinicians saying we want to find things that help people, fair enough. But we also want to know what form of life is this conducive to? And this morning we're having a conference here on placebo, and part of the discussion is around what does it mean to give somebody a pill? Because that is what Wittgenstein would call a form of life. It's a certain way of living. When you think that you have a problem, you take a pill. And it may be very efficacious for a whole variety of reasons, including that you believe it's going to be efficacious. But it may have unanticipated and undesirable effects as well. And in the article I think I gave you to read on globalization and psychopharmacology, I try to talk about this dilemma from exactly this point of view, of saying, look, a meditative practice is many things. It's also a practice and a discipline. And so you are learning many things along the way, not just maybe how to feel better and so on. You're learning a lot of things about how you live and how you regulate yourself and so on. And maybe some of those other things are desirable for other reasons, not just because they help you to feel better. Maybe they have other consequences. So we need to have that discussion, and that discussion is only going to come from a cultural analysis. It says, what does this thing do in situ? What does it do in a new context? Because in a way, I use the word context probably too much here, but I think it is an abstract word for what culture is directing us toward, looking back to the life world, looking back to the relationships, looking back to the everydayness, both experientially but also in links to other people and to institutions. So these are the future tasks for cultural psychiatry, trying to understand the phenomenology of mental disorder as a basis for clinical empathy and care. Oh, it's just about time for us to stop here. And let's go, and it's a glorious day outside, and let's still try to enjoy a little bit of that. Okay.